good afternoon. Thanks everyone. Thank Dr. Tedesco for inviting me to this amazing meeting. So, Italy is very close to my heart, and it's so nice to be in South Italy. Never been here before. So, thank you for this invitation. So, the slides. So the question was, how would the dry eye management affect your management of doing cheratoplasty? Just waiting for the yield. So I suppose a question people will ask, what's the influence of the dry eye disease when it comes to doing cheratoplasty? Ocular reconstruction, whether you're doing corneal transplantation, stem cell transplantation, etc., and how management of dry eye would be important or necessary after cheratoplasty itself. So it doesn't really matter whether you're doing cheratoplasty or you're doing cataract, it's to do with ocular surface management, and that's what I'm trying to cover a few things. I'm going to show you a little bit of extreme here, but just to highlight how important to control eye surface inflammation, because it could lead to disasters from losing the homeostasis of eye surface, just a bit of dry eye, to the extreme loss of the stem cell function and end up with the cloudy cornea. So what are we trying to control here? We try to control the ocular surface microenvironment, the inflammation. We try to stop any corneal new vessels, which is a product of the ongoing inflammation. And we try to make sure that the corneal sensation remains intact. And as you've probably seen this before, this is not about just the tear film. It's a huge picture here where you have a factory, conjunctiva, corneal nerves, cytokines, tear film, all involved in that, creating that perfect microenvironment on the eye surface. So, and we know that you need optimal protection, and again, yes, tear film quantity and quality is very important, but if you don't have the right mechanism to maintain that, then you just supplementing new tears is not enough. All you need to work around is, are the lid functions right? Lids in a good position and functioning, that they blink, and how effective that blinking, etc. You need to look at the sensation of the cornea. Does the cornea sense the right information, so you get the right response? And then you look at the accessory glands, the lacrimal glands. And obviously the eye surface, remember all this aqueous production coming from those cells sitting on the goblet cell from mucin, or accessory cells sitting on the conjunctiva, all responsible for the aqueous production. So if you have a conjunctival disease, you're missing that part of the tear film. So this is system where 4 systems actually affecting the ocular surface stability: the innervation system, the endocrinology system, vascular system, and immune system. So the big 5 I also ask you to look at when you're assessing ocular surface disease is 1, the lid function, 2, is this eye wet or dry? 3, is the eye inflamed or quiet? 4, what is stem cell functionality? And 5, is the cornea sensation normal? All these 5 questions have to come to our mind every time we assess eye surface. So this is an example. This is a child with ichthyosis. Can't close his eyes. Have 2 identical cornea transplantation when he was very young. All happened due to exposure, cornea melt, perforation. The second cornea graft was emergency because the cornea just melted down completely. So what's the answer for this little boy? You can't do skin graft because all his body like this. This is the ichthyosis condition. So what's the best things to do? Think about what we use in the cosmetic surgery is the fillers. So use the fillers as tissue expander to expand that skin and allow this little child to close his eyes. And amazing results. So I managed to do a 3rd cornea transplantation, and this is 2013 in the picture. So now it's 10 years. I'm still seeing this child. He's grown up now, and the cornea graft maintains its clarity. He comes every 6 to 12 months. What I do is just do a little bit of fillers. A simple treatment, but it sorts out this problem. It's all about cornea protection and ocular surface, the microenvironment. Another case, this child with anterior segment degenesis anomaly, same problem. Children have a dry eye, they don't blink fully, they don't blink well, but as long as they have a mechanism to restore the balance. If that tips in the wrong direction because they have additional ocular surface disease or corneal problem pathology, then they end up with having a picture of dry disease, ocular surface filler, and so on. So same story with this child, and we did the fillers, and again you can see managed to contain his cornea clarity and cornea transplantation. So when it comes to ocular surface inflammation, you need to think about why this eye is inflamed. Are we talking about systemic condition or is this a localized condition? And don't underestimate the rosacea. It's so common, more than you ever think. So you need to, in elimination, and that's what when you look at the TIFOS, the DUCE 2 report told you about, it's about elimination, modification, and trying to alteration of things we do. Whether drops you put, they have preservative. Are they putting drops that have more toxicity to the eye surface? Are we protecting the eyes? Can you swap this with that one? And you need to treat the comorbidities, obviously. You've got the lid margin. As you can see in this picture, these lids are rounded, they're really inflamed, they're sweating with the inflamed cytokines affecting the eye surface. And it's no wonder this patient keep having those calcium deposits, keratoplastica, because the eye surface is so bad, the tear film is so thick. So you need to treat the inflammation, and thanks God now we have the cyclosporins, we have the tacrolimus. This is our non-steroidal immunomodulatory systems, devices which are used now to protect the eye surface for long term. Because one of the things that I'm sure you've seen when those patients need a steroid, and they will need a steroid for long term, you can't just keep them on a steroid. They're going to get steroid response, they're going to get all sorts of problems. So yes, you give them short course of steroids to control the inflammation. And please remember dry eye disease as ocular surface inflammatory disease. This is it. It's not just about water, it's inflammation. And obviously, people think that the amniotic membranes are a bit last stage, the allogenic or alloteres, all that last resort. It's not. Now we're using much earlier stage. We have something called omnilens. It's amniotic membrane attached to the contact lens and you stick on the eye. And it's amazing how you see sometimes the inflammation switch off so quickly and the ocular surface is much better. So, and again, when you deal with inflammation, remember, is this active inflammation or in the damage? Often I see some colleagues treating the damage of a surface as active inflammation. The damage is damage, you have to deal with a different way, but the inflammation is inflammation. It's to look for the signs that something happening actively. The injection, the hemosis, the staining on the ocular surface, the lid margin activity. If you have the tools to look at the moving lens function, the tear film osmolarity, all those signs, MMP39. It's all these tell you about the functions, the activity of the inflammation. The comorbidity we talked about. So if you have no phonesis, you don't have that tear meniscus. You don't have the volume of tears. Remember, the tear meniscus is your first wave of water. When you blink, that will spread on the eye surface. But the reservoir is in the fornices. That's why if there's no fornices, you don't have that reservoir. And one of the simple tests to check is this eye at rest is to suck that tear film. Get a tiny cotton bud and just suck that tear film to your meniscus and see how quickly it replenishes itself. The water will come back. If it replenishes itself quickly, it's a good sign. If not, it's a bad sign. That means the patient is really a serious problem. Corneal vascularization, you have to treat them before cheratoplasty. You can't allow the autoregulation to be compromised because those vessels grow, it's sitting in the cornea and leaking. Remember, those are bad vessels. They don't have the pericytes, so they're leaking profusely. And when they're leaking, they cause a lipid deposits. They put at the graft and whatever you do in the future at very high risk of rejection. So sometimes so what we do, if it's an active vessel, I do fine needle diathermy when you burn the vessels, but then you use subconjunctival Avastin anti-VEGF to try to stop the proliferation. Never do fine needle diathermy without anti-VEGF, otherwise the vessels will just simply come back. Sometimes you have to do, unfortunately, there's no protocol, there's no standard, you just have to go by your experience and see how many times you have to do multiple injection of Avastin. But we managed to stop this cornea from getting clogged, especially when it comes to children. You try to minimize the impact, don't want too many surgeries, don't want too many grafts. So if you stop those vessels, you prolong the time with the corneal clarity. And when it's stem cell deficiency, please look at those things because it's very important. It might look like stem cell deficiency suddenly appear and people say, oh, this is something that there's a panels, the ocular surface problems, the corneal clarity, but you have to look at the early signs. There's nothing happen overnight. The stem cells are fighters. They really fight to the last minute, so they're not compromised or they don't lose them so quickly, but because of the chronic inflammation that missed often, that will lose them. And I encourage you to look at the early signs of stem cell deficiency. And where is it? Is where we don't normally look at, is under the eyelid. You have to look at the superior limbus, where you see the early signs of stem cell deficiency. That's the part we don't really bother lifting the lid to see what's going on. But again, if you have an inflamed ocular surface, remember who's vulnerable here? Those stem cells. So if you have an ongoing inflammation, that's chemosis, conjunctiva, we mentioned conjunctival callosis, obviously it's called chronic friction of the conjunctiva, release of cytokines. It's not just about the bit redundant conjunctiva. So this is the kind of signs you see when you lift the eyelid, and if you can appreciate on the top eyelid, you put this drop of fluorescein and you can see actually the arrangement of epithelium is funny here. They start to lose that normal corneal reflection of fluorescein, and you can see those lines. And in fact, and you see the lack of reflection, nice reflection of the center of the eye, obviously the vessels, the planus, etc. And there was a nice paper by Professor, this one. So this is an advanced picture. You should not wait for this to happen. This is a total stem cell deficiency. There was a nice paper by Professor Dua which showed you that actually, if you look at the superior conjunctiva, superior cornea, that's where you see the early signs. And all this on the top, you can see these signs of early stem cell deficiency. So please use a fluorescein drop and lift the eyelid, look at the superior cornea. That tells you a lot of information. You know these eyes are at risk. Because at this stage we can manage it easily. But when it's all spread around and you lose the stem cells, this patient will need a stem cell management. And remember, the clinical picture is not static. So what you see today, like some of those pictures with stem cell deficiency, is not going to happen in a few weeks. You might find things start to change, right? Hopefully for the better. So obviously there is signs of advance where you become persistent ear defect, loss of fluorescence, the lack of full advance that you don't want to get to that. So the early management is good, which is to protect the eye surface to reduce the inflammation. Very simple, it's nothing too complex, they just want the tools to do that. And if the eye is dry, it's a bad news because this patient, no matter what you do, they tend to fail. If it's wet, it's a better news, and you can restore the eye surface integrity. So it's again all about controlling the eye surface inflammation, optimizing the tear film, make sure that the cornea has inflammation. You want to restore sensation if it's missing, and we have to also restore sensation now. You need to treat any comorbidities, and because you want to store the microenvironment of the homeostasis of the eye surface. So I stop here, and thank you very much for listening.